Hello guys, this is Dr. Turpin. I'm going to review some key points related to Chapter 21, which goes over multi-drug resistant infectious disorders. This is just some basic information that kind of reiterates mode, routes of transmission, and how infection takes place. But to get right into the different types of organisms, methicillin-resistant Staphylococcus aureus comes from a Staph aureus germ that has had incomplete exposure to drugs in the psyllin family, and methicillin being the most common. And so, as we know, patients who have taken drugs in the psyllin family, it may make certain strains of the Staph aureus become resistant to it, and it's no longer really effective. So then that limits down the drugs that are available to treat this when it becomes a new infection in someone else. It is aerobic. It is a gram-positive bacteria, and it's important to kind of note, when you see some of the types of infections, whether it's gram-positive, gram-negative, whether it's a cocci or rods, because when you get cultures called back from the lab to the floor that are positive for something, they're going to tell you, if it's just the first 24 hours, they cannot fully identify the precise germ at that point, but they will tell you whether it's gram-positive or gram-negative, and whether it's cocci or rods, and then that's the report that you call to the physician to let them know that you have a positive culture. And from that, the physicians are able to kind of identify, well, if it's in this particular category of bacteria, then more than likely it's probably this type of specific germ that is going to be resultant in another 24 hours when the petri dish fully grows out. So they use that to kind of judge what kind of antibiotics to start someone on, or they'll go back and review if they started somebody on something in the ER. Now that I have this other piece of the puzzle, do I change or refine that? And then again, in another 24 hours or 48 more hours, then you may get a more definitive culture result, and then again they may refine the antibiotic therapy again. It's important to note for all of these diseases, whether they're healthcare acquired or community acquired, but I will tell you that with MRSA, it is very much more widespread in the community and growing in the community, where the other two infections we're going to talk about are not so much so. But it's very important on the front end to really evaluate the patient and make sure, did they have reasons to become infection in the acquired in the community, because if for some reason that doesn't get caught, and then 24 hours later they're in the hospital and start having symptoms of an infection that weren't previously documented, then the hospital eats the cost of that stay, because then they deem it a healthcare acquired infection. And then there's this concept with MRSA and some other resistant infections. Was this something that was developed internally to the patient versus contact transmission? Of course, contact transmission for MRSA is very high, but there are some patients that will have Staph aureus type infections that they're getting treated for repeatedly. And they may be getting treated with some drug in the psyllin family, and it didn't really kill it all, and so then internally they sort of flare up with this again, and now it's a resistant MRSA, whereas the first time it was just a Staph aureus infection, or the first couple times. So just being aware that that can actually occur, even though that's not the most likely way that it's transmitted. Clinical manifestations of MRSA include lots of sites of infection, can be pneumonia, skin, soft tissue, surgical site infections, bloodstream infections, and occasionally urinary as well. I will say, for those, if you've had a patient that had a skin or soft tissue infection, it's pretty easy to kind of tell. These are wounds that may start out as a little small pimple area with maybe a little pustule on the top or draining just a little bit, and they will often grow dramatically in size over a day as they begin to work, and the infection takes over, and patients have had huge wounds within a day that have opened up or required to be opened up and excised to allow them to drain. And they usually have to be packed with wet to dry dressings, which create unbelievable pain for the patient. And the same kind of thing can occur in a surgical site infection and then open that wound back up as well. The big thing in terms of complications is trying to keep them from going into septic shock, because it leads to a huge 50% mortality rate, which you want to try your best to avoid. These are some of the typical treatment nursing actions. If it's a minor infection, they may be put on oral clindamycin or Bactrim. The most commonly prescribed antibiotic for treating MRSA is IV vancomycin, and you will see that very frequently. Of course, we know with that particular drug that you have to do peak and trough levels to get the right level of the drug in the system, and that also is kind of evaluated based on their kidney function and their ability to tolerate that drug. We use contact precautions to prevent disease spread from patient to patient, and we have to do adherence to hand hygiene, both hand washing and hand sanitizer. Patient education is important for teaching them how to prevent this if they're, say, going home on a past a surgery event. And then if patients have had MRSA, it's real common sometimes for them to have infections in more of a remote place that maybe then recur again with the same thing. So teaching them how to recognize that potential. We spend a lot of time monitoring the site of the infection, watching vital signs, making sure that we're not seeing subnormal, real high temps, which can be signs of shock, and a few other vital sign changes that I know you're aware of. With temps over certain numbers, sometimes you'll have protocols to go ahead and get blood cultures. We're monitoring white blood cell count. Again, wound care sometimes can be very extensive and very painful, requiring a lot of packing into the wound. So pre-medding patients with some pretty quick-acting IV pain medication, and then keeping them on something more long-acting for pain is pretty important during that process for those that have the wound infections. In terms of VRE, it's the third most common nosocomial infection. We do have enterococci that live in the GI tract and the female genital tract normally. Although they're not resistant, but they do live there. It is a gram-positive cocci, and what happens is that enterococci that lives there normally develops resistance to vancomycin, sometimes with repeated cases of this antibiotic being used. Just like, what if you came in and again for MRSA and recurrence of MRSA? You're getting a lot of vancomycin, so it's pretty common for those patients to then test positive for VRE. which then gives them 2 resistant infections. And of course, transmission also occurs through contact, which is the biggest risk factor. The sad thing for vancomycin is that it can remain viable on environmental surfaces for 7 days to 2 months. So of course, cleaning after someone is discharged or leaves, and even daily cleaning just to keep down any of this off of environmental surfaces in an isolation room are very important. Typical things that you'll see with VRE is UTIs and usual symptoms there. Peritonitis can occur. They can, of course, develop bacteremias that can lead to multi-system failure, where they end up in the ICU. Wound infections can happen and, again, are very red and hot. VRE can also the germ can vegetate and cause then later endocarditis symptoms. So it's good to monitor them related to heart function. As I said, patients on vanc for long periods of time for MRSA could develop a VRE. And then we are seeing some cross emergence of vancomycin-resistant Staph aureus as well, because a gene has been transferred between the 2 organisms from all this cross contamination issue. Treatment, you'll see these drugs at the top. Most of the time for VRE, there's like a first-line drug, which is some of these first 2 or 3. Coupled with a secondary drug. And not all of those are really effective sometimes, so it takes some, trying some things to see. Again, contact precautions, strict hand hygiene, prevention and prevention of recurrence, monitoring the site of infection again, same typical things that you're watching for, and with the caveat of monitoring the heart very close for signs of endocarditis. And you may even see them order like echocardiograms and things to double check that as well. Lastly, C. difficile or Clostridium difficile. It's the most common cause of antibiotic-associated diarrhea. 50% of hospitalized patients will be colonized, may not show any signs of the disease. And it is a gram-positive bacillus, but it is spore-forming. And so it's important to know that, because spores, if they're sitting on a surface and you wave your hand, or you had a fan in there, or somebody walks by with a gown on, it will make those spores fly up in the air and redistribute on a surface area further over from that. So when you imagine someone trying to clean the room from housekeeping, when they go to wipe something, they in a sense kind of don't totally wipe it. It kind of just floats off and away, making it pretty hard to kind of control. C. difficile comes from, most patients that have it will have had some recent use of antimicrobials such as clindamycin, cephalosporins, or fluoroquinolones, and that could be from a different type of infection. It is often transmitted through an oral fecal route, basic contact with a contaminated environment, direct contact with the patient, or through our contaminated hands. To find out for sure if somebody has C. diff, you've got to do a C. diff toxin and stool, and it has to be almost a watery stool for them to do the test. So if they've got formed stool, it's really kind of no point to send it. The patients may not have a lot of symptoms, or they may have really moderate to severe diarrhea with a very strong noticeable odor. And the biggest thing you're really looking for them is the symptoms of, checking bowel sounds, as well as watching for signs of dehydration and hypovolemia. this is some of the treatment things related to that. And just again, we're going to really watch their electrolytes. We're going to watch, how much intake they're having versus how much diarrhea stool's coming out to really keep close watch on INOs. They are on special enteric contact precautions that requires you